Hi, my name is Reed Kenny, and I'm a rising senior at Duke, majoring in public policy and global health.
Hi, my name is Ainsley Buck, and I'm a rising junior at Duke, majoring in neuroscience with a minor in psychology and certificate in child policy.
Ainsley and I have been working on a Bass Connections team for this past year that's working on measuring and addressing social emotional health in young children. And this past summer, we worked specifically with Dr. Rashina Chalera, Dr. Michelle Franklin, and Dr. Jillian Sanders-Schmidler. So our project was motivated by the North Carolina Early Childhood Action Plan, and this was published in 2019 and outlines 10 specific goals for North Carolina to reach by 2025. And these goals fit into 3 categories: that all North Carolina children will be healthy, safe and nurtured, and learning and ready to succeed. So our work specifically focused on goal number 7, which is to have a reliable statewide measure of young children's social emotional health and resilience at the population level. So we examine the national landscape of social emotional health screening for ages 0 to 5, looking specifically at the barriers and recommendations for implementing screening. And then we're working on providing North Carolina Department of Health and Human Services with recommendations to implement population level social emotional health measurement. So social emotional health encompasses several domains, including a child's ability to regulate their emotions and temperament, express wishes, and follow directions. And social emotional health is important because early childhood social emotional health has been shown to be predictive of multiple long-term health and economic outcomes, including educational attainment, occupation, and criminal charges, among others. And as healthcare shifts to value-based care, there's more emphasis on preventative care and addressing root causes of health problems. So now we're going to talk about how you can go about measuring social emotional health. So you can use a screener, which is a tool that detects indicators for potential concern. However, this is not a diagnostic tool. So a positive score on a screener can indicate that there is some concern regarding a child's social emotional health and that they may need further evaluation. And there are 2 main types of screeners, and this is individual and population level screeners. An individual one assesses a single child, while a population screener gives an estimate of the general social emotional health of a larger group. Social emotional health is important in North Carolina because it's been estimated that up to 14% of children in the U.S. experience social emotional health disturbances. However, there is very little data on this, and because of this, North Carolina would like to be a leader in collecting this type of social emotional health data.
So to begin our study, we first conducted a literature review to get a sense of the current landscape of what social emotional health work was going on across the country. And we found that the vast majority of the literature was focusing on linking early childhood social emotional health to those longitudinal outcomes that Reed mentioned earlier. And there was very, very little work on actually implementing social emotional health screening. So we then moved on to semi-structured informant interviews, and we'll go over the content of those interviews in a little bit more detail on the next slide. But we took the content from those interviews and developed some distinguished themes and used those themes to formulate recommendations for implementing screening. So more specifically, our interviews focused on the current efforts to monitor and collect data on early childhood social emotional health, as well as implementation barriers to implementing social emotional health screening, and policy levers that would help to accelerate the use of social emotional health screeners. This graphic gives you the geographic distribution of our informants. So the lighter blue color are where we specifically spoke to informants in those states, which was 19 different states. But importantly, we also spoke to 8 different national early childhood organizations. So we still got the broad scope of what was going on across the country. And our informants came from a variety of different sectors, including early education, policy, mental health, physical health care, and research, which really helped to round out our perspectives of all different sectors involved in early childhood. And then once we synthesized our data, we developed 2 distinguished sets of recommendations. The first was policy level recommendations, which we thought was more relevant to policymakers at the higher up level, and then individual level recommendations, which was most relevant to providers that would actually be administering the screening. So that would include pediatricians, nurses, child psychologists, or really anyone else who might be providing healthcare in early childhood.
So in terms of our results, our recommendations for policymakers fit under 4 main themes, and this was individual and population screening, reimbursement, data sharing, and equity. So the main barrier for individual and population level screening is that individual screeners cannot be aggregated at a larger level. And our informants recommended that the state use both individual and population level screeners to gather the most data possible for early childhood social emotional health. In terms of data sharing, the main barrier was the lack of overall use of the current data sharing systems that have already been created. And our informants recommended that policymakers in the state create mandates to utilize existing data sharing systems such as the Early Childhood Integrated Data System, CHADIS, or Enterprise. And this also helps to promote cross-sector collaboration because healthcare right now is very siloed. In terms of reimbursement, the main barrier is there's a lack of funding for social emotional health screener. And our informants recommended that policymakers incentivize providers to screen through financial policies. This also would include potentially expanding Medicaid to cover social emotional health screening.
For providers, our themes fell into these 4 buckets of prioritizing social emotional health, selecting a social emotional health measure, accountability, and equity. So the main barrier to prioritizing social emotional health is that there was an overall lack of understanding of the importance of it, especially in families. So informants recommended that parents were educated during their well visits on the significance of social emotional health so that they would be more inclined to complete a screener, as well as incentivizing social emotional health screening for providers because their workflow is already so busy. Then in selecting a social emotional health measure, one of the main barriers was balancing the length or the time it takes to complete with the comprehensiveness or how thorough of a picture the screener provides of the child, as well as workflow integration. And the most commonly cited screeners were the Ages and Stages questionnaire specific to social emotional and the Survey of Wellbeing for Young Children. And so we're going forward recommending those because they've been successfully implemented in practices across the country, as well as integrating whatever measure is selected into the electronic health record because that helps to streamline the screening process for providers and make it more time efficient for both families and providers involved. And then lastly, for accountability, there was both provider and family apprehension to screening, which was particularly exacerbated when there wasn't a follow-up procedure in place. So our informants recommended standardizing that follow-up procedure, whether that be with a referral form or another way that works better for the practice, as well as utilizing the existing data sharing systems that Reed mentioned earlier, like ESIDS and CHADIS, because that furthers cross-sector communication and communication between any relevant sectors. So a great example of that you all are probably familiar with is NC Care 360. And then across both of these buckets of recommendations, equity was a large concern, and we found that informants thought that equity needed to be further prioritized throughout the entire implementation process from the very beginning stages. And we had several various recommendations for how to address this. So first, there are not any equity-based measures currently in use, but there are a few in development. So it will be really important to allocate funding to validate those measures moving forward. And then until they are available, ensuring that whatever measure is being used is appropriate for the population being screened so that screen scores are not skewed in one direction or another, as well as improving accessibility of follow-up resources to ensure that giving someone a screener and having them come out with a positive screen doesn't do more harm than good if you don't have anything for them to do after to address the concern. So currently we're in the process of developing an implementation framework for social emotional health screening for North Carolina Department of Health and Human Services. And we are working on publishing these manuscripts as companion pieces, with one targeting policymakers and the other targeting providers. And we just want to thank the rest of our team and our interview participants, and we're welcome to any questions now.
Great, thank you. So open this up for questions. I actually have a question. So I know that when we did the interview, so obviously it was largely, the interviews were completed before the coronavirus occurred, but that obviously as we're looking forward to the impacts of coronavirus, especially on the children, going forward, you know, the social and emotional health is going to be something that people are both aware of and also that might have issues. And I didn't know if there would be any changes you would think about in terms of the themes based on some of the COVID happenings and looking forward?
I think this would just place a larger emphasis on equity, just because in terms of like telehealth visits and things like that, there's definitely different populations are like unable to do certain telehealth visiting because of like lack of technology or Wi-Fi and things like that. So I think equity just plays a larger role in who gets screening, and I think accessibility to resources for follow-up is also more of a problem with the pandemic.
Yeah, I was going to say something similar. I think in general, there's a shortage of child mental health experts from what I have heard and read about, but right now the need is greater than normal. So that disparity is sort of just getting larger.
Great. Any other questions from folks?
So
okay.
Jill,
oh yeah, Susan.
I just put one in the chat, but I'll state it now. So this is really great work. Congratulations to all of you. As you know, there are screening tools that have been developed for adverse childhood experiences that are gaining use. Do you think those are a useful building block for some of the screening tools that should be built to look at the broad array of SEH-related factors?
Yeah, so I think a lot of the measures for ACEs and other social determinants of health as well have been used as proxy measures for social emotional health a lot moving forward. And I think that looking at those proxy measures and if they have better ways to address equity or some of the barriers we're seeing for social emotional health specific tools, they're definitely helpful models to work off of.